Hi, my name is Cassidy, and I will be presenting gastroesophageal reflux disease, or GERD. Here is a table of contents for an overview of the content on this PowerPoint presentation today. Gastroesophageal reflux, or GERD, is an incredibly common condition affecting the gastrointestinal system. It can be defined as the upflow of stomach acid beyond the stomach and into the esophagus. This acid exposure results in inflammation and damage to the esophagus, resulting in the symptoms that commonly present with GERD, such as heartburn. The diagnosis of GERD can be confirmed through these symptoms described by patients, along with their responses to proton pump inhibitors, or PPIs. Because GERD is very common, there are a lot of associated risk factors and etiologies associated. Mainly, GERD can occur due to alterations in the function of the lower esophageal sphincter due to over-relaxation or poor motility and inability to contain stomach contents. Other reasonings for GERD may include increased abdominal pressure as seen with hernias, pregnancy, and obesity, or a lack of defense mechanisms in place such as through saliva and epithelial layers. Risk factors for GERD include male sex, Caucasian race, an age greater than 50, smoking tobacco, alcohol use, as well as psychological factors such as stress, depression, and anxiety. When covering the pathophysiology of GERD, the mechanisms are dependent on the etiology. As an example, stomach acid can present into the esophagus due to regurgitation from improperly functioning esophageal sphincters. This can be a result of a multitude of reasons, but is often due to poor tone of the esophageal sphincter, resulting in the inability to contain stomach contents. However, in a patient who has a hiatal hernia, there is an anatomical disruption between the esophagus and the diaphragm, causing an improperly functioning esophageal sphincter. Additionally, the hernia itself can result as a reservoir for containing stomach acid, resulting in further irritation. Other pathophysiology processes can include increased pressure from increased abdominal circumference, as seen in pregnancy and obesity, resulting in an increased pressure and frequency of the esophageal sphincter to relax. Additionally, defense mechanisms can be compromised, leading to worsening GERD, such as with low saliva, which results in a limited ability to neutralize stomach acids. Impaired defenses can also result from repeated damage to epithelial barriers, affecting tight intercellular junctions, cellular buffers, and cellular membrane transporters, resulting in a reduced epithelial defense and an increased blood supply. Over time, this repeated damage can result in Barrett esophagus, in which cytokines and inflammatory cells are mediated as a result of an increase of HIF2 alpha in activated B cells, resulting in further damage. The most common subjective data for those with gastroesophageal reflux disease include regurgitation and pain. Regurgitation occurs as a result of stomach contents entering the esophagus, resulting in a description of an acidic taste notable in the mouth or throat. The pain, on the other hand, is described as more of a burning sensation that often occurs 60 minutes after eating a meal and is worsened by bending and originating in the epigastric area with potential to radiate to the neck. Because of this area of pain, it is imperative that cardiac conditions are ruled out if the presence of chest pain is reported. Additionally, atypical presentations of GERD may include a chronic cough. Although subjective data collection will be most helpful for assessing potential GERD, the physical exam has some key components of note as well. In patients with GERD, surrounding areas of the esophagus can be damaged, resulting in physical changes. This can include dysphonia, sinusitis, laryngitis, and dental erosions due to the repeated exposure to the acidic nature of the stomach. Other more alarming symptoms can also occur, such as weight loss or hemoptysis, which requires a further workup. However, the exam for a patient with GERD may be The exam may be relatively benign otherwise. Based on associated objective and subjective data collection, there are a few differentials that need to be considered. For the reporting of pain anywhere near the chest, cardiac diseases such as coronary artery disease needs to be considered to ensure nothing serious is missed. Other options for differentials will mainly surround the gastrointestinal system and can include peptic ulcer disease, infections such as H. pylori, movement disorders and cancers affecting the esophagus, as well as gastroparesis. Careful history and further diagnostic workup can assist with guiding the best diagnosis for each individual. For collection of data to assist with supporting differential diagnosis, one of the most common options for supporting a diagnosis of GERD is the trial with a proton pump inhibitor, or PPI. This trial takes place for up to 8 weeks and a reassessment on symptoms is complete. A positive response and improvement in symptoms indicates a likely diagnosis of GERD. For those who are experiencing much more worrisome symptoms associated with GERD, such as weight loss, or those who are at high risk, should be evaluated through endoscopy prior to PPI trial. Close attention to esophageal mucosa can be evaluated through this, along with grading of any damage that is found. Other tests may include barium swallow imaging for assessment of abnormalities throughout the esophagus. For patients that are presenting with any symptoms that could indicate potential cardiac involvement, an evaluation should be complete, such as with an EKG. There are two main drugs that are utilized for the pharmacological management of GERD. PPIs are used for first-line treatment and are best for erosive esophagitis. It is best taken 30 to 60 minutes prior to a meal at the lowest dose possible for effective pharmacological management. With PPIs, side effects should be monitored as well, which can include hypomagnesemia, infection, vitamin B12 deficiency, and rebound acid secretion. If PPIs themselves are insufficient for symptom management, then H2 blockers can be considered in conjunction or in replacement of PPIs. Lifestyle changes can be a crucial point in patient education with a diagnosis of GERD. This can include promotion of weight loss, limiting of alcohol use, and smoking cessation if applicable. Other considerations to include in patient education surrounding the plan of care should include avoiding meals prior to bedtime, keeping the head of the bed elevated, small frequent meals, stress relief, and diet adjustments in order to minimize acid within the esophagus. Adjustments to diet can also assist in promoting a healthier gastrointestinal system while minimizing acid that causes GERD. As an example, addition of fiber within the diet through foods such as whole grains and oats can promote a reduction of acid. Other foods such as yogurt, almonds, and bananas work through neutralizing stomach acid and restoring healthy bacteria through probiotic introduction to the GI system. Additional food options to support a healthy GI system and minimization of GERD symptoms include papaya, ginger, turmeric, and chamomile tea for their anti-inflammatory properties. And these are my resources. Thank you so much for watching.